Assalamualaikum and very good morning. My name is Dr. Noliana from the Institute for Public Health. I will present today the findings from my manuscript entitled Self-reported Diabetes, Hypertension and Hypercholesterolemia among the Elderly in Malaysia. Diabetes, hypertension and hypercholesterolemia are established risk factors for cardiovascular diseases. Ischemic heart disease and stroke are the main causes of premature death among the adults. Global projection of death rank IHD and CVD as top reasons for death from 2002 until 2030. Additionally, mortality related to diabetes is projected to increase by 4 ranks in the same period. Since year 1991 to year of 2010, Malaysian population aged 60 and over has increased from 1 million to 2.2 million people. The elderly population is projected to rise further to nearly 18% by 2040. This is projected to increase over time and overtaken the younger population. Increasing trends of health problems and healthcare utilization were observed among the elderly worldwide and in Malaysia. In Malaysia, cardiovascular diseases were the leading cause of death from 2017 to 2019. IHD has increased by 54% within 10 years duration. The high prevalence of the three ailments, diabetes, hypertension, and hypercholesterolemia, in the elderly age group noted to be the main contributor to the national prevalence. Additionally, health services utilization in Malaysia increased with age for both inpatient and outpatient care services. This study aimed to determine the prevalence of self-reported diabetes, hypertension, and hypercholesterolemia among the population aged 60 years and older in Malaysia. We also examined the factors that are likely to be associated with the self-reported of each disease. Findings from this study can provide the baseline for the health policymakers and elderly caregivers to enhance the health promotion and services to perfectly suit the elderly in Malaysia, in line with the policy framework for healthy aging. This study used data from the National Health and Morbidity Survey, NHMS 2018. It was a cross-sectional study and nationally representative health survey of the elderly population aged 60 years and above. The survey used a two-stage stratified sampling design to ensure national representative of the targeted population. The sampling frame for this survey was provided by the Department of Statistics Malaysia and updated in 2017 prior to the sampling process. The chosen sample was randomly drawn, and all households and persons aged 60 years and above within the selected LQ were included in the study. This study used STEPS questionnaire, and the dependent variables for this study were self-reported diabetes, self-reported hypertension, and self-reported hypercholesterolemia. Respondents were classified as having diseases if they were told to have it by medical personnel previously. A total of 7 social-demographic variables and 4 selected variables on functional status, lifestyle factors, and chronic diseases were included as independent variables in this study. Social-demographic variables included sex, strata, ethnicity, educational level, marital status, employment status, and individual monthly income level. Lifestyle factors comprise of smoking status, body mass index status, and physical activity status. Data analysis was done using SPSS Statistics version 25. The complex sample analysis procedures were used in the analysis and was carried out at 95% confidence interval. Descriptive statistics was used to summarize the characteristics of the study population. Univariable and multivariable logistic regression were performed to investigate the association of self-reported diabetes, hypertension, and hypercholesterolemia with various independent variables. 3 different models were developed in the analysis: Model 1 for self-reported diabetes, Model 2 for self-reported hypertension, and Model 3 for self-reported hypercholesterolemia. As for the results, the total number of respondents was 3,977. The mean age of the respondents in this study was 68.3 years old with HD of 7 years. There were almost equal proportion of male to female and urban to rural respondents. More than half of the respondents were Malays, had education less than high school, with spouse and partner, currently unemployed, retiree or homemaker, and had income less than 1,000 per month. The prevalence for self-reported diabetes, hypertension, and hypercholesterolemia were 27.7%, 51.1%, and 41.8% respectively. The prevalence was higher among female than among male, and there was significant difference between the two genders among self-reported hypertension and hypercholesterolemia. Indian had the highest prevalence for self-reported diabetes and hypercholesterolemia, while other Bumiputras had the highest self-reported hypertension. Retiree or unemployed, non-smoker, obese, presence of other comorbidities had significantly higher self-reported prevalence for all three diseases. Respondents who were physically active had significantly lower prevalence of self-reported diabetes and hypertension. No significant difference was observed between strata, level of education, and marital status. The multivariate analysis demonstrated that those with presence of other comorbidities have highest odds for self-reported of all three diseases compared to those without any comorbidity. For self-reported diabetes, the highest odds were among Indians, obese, unemployed retiree, and inactive respondents. For self-reported hypertension, the highest odds were among other Bumiputras, non-smoker, obese, unemployed, and those who are inactive. For self-reported hypercholesterolemia, the highest odds were among obese and non-smoker. Generally, the prevalence were higher than in South Korea, with self-reported diabetes, hypertension, and hypercholesterolemia among population aged 50 years old and above at 13.6%, 36.4%, and 11.7%. Among those 60 to 69 years old in South Korea, prevalence was 17.5, 40.5, and 14.2 respectively, and among those aged 70 years and above, they were 15.2%, 47.5%, and 6.6% respectively. For diabetes, Malaysia had higher self-reported prevalence than Brazil at 15.4%, among Arab Americans at 5.7% among age group 46 to 85 years old, and even Hong Kong at 13.7% in male and 13.9% in female aged 65 years old and above. Prevalence of self-reported hypertension was 51.1%, which was lower than in the United States at 53.8%, but higher than in Canada at 48% among elderly aged 65 years old and older. And in urban Brazil, where the prevalence of self-reported hypertension was reported at 49%. Presence of other comorbidities showed highest odds to have self-reported prevalence compared to other factors. It could be due to the presence of other risks for cardiovascular diseases. It increased the knowledge and awareness of others. This can be explained by the increase of health screening among those diagnosed due to the presence of their other diseases. Higher odds were seen among obese and physically inactive respondents. Obesity shared many similar abnormalities with diabetes, hypertension, and hypercholesterolemia. These abnormalities include several central and peripheral abnormalities such as activation of sympathetic nervous system, renin-angiotensin-aldosterone system, endothelial dysfunction, renal functional abnormalities, and also similar mechanism regulating the appetite and the metabolism. Meanwhile, the prevalence of physical inactivity was positively associated with hypertension and diabetes. People who maintain a physically active lifestyle develop impaired glucose tolerance and diabetes less often than those who lead sedentary lifestyle. Exercise increased tissue sensitivity to insulin and reduced the blood pressure of individuals with hypertension. Those who were unemployed had significantly higher odds to have self-reported diabetes and hypertension. Previous studies showed that low occupational status, concern about job stability, feeling less than very good at one's job, social detachment, and depressive symptoms had significant association with cardiometabolic conditions. From this study, Indians had higher odds for self-reported diabetes, and other Bumiputras had higher odds to have self-reported hypertension. It is concurrent with findings from other studies in Malaysia, which showed higher risk of diabetes among the Indian and higher risk of hypertension among the other Bumiputras. Meanwhile, the non-smokers showed higher odds to have self-reported hypertension and hypercholesterolemia. This could be due to the non-smokers are more health conscious compared to the smokers, hence they are more aware of the health status. There was some limitation and strength in this study. Since our study was cross-sectional, the temporal relationship cannot be established and it could only reflect the association between the prevalence and risk factors. Nevertheless, establishment of associated factors with diabetes, hypertension, and hypercholesterolemia, specifically for the elderly, could contribute to the formulation of public policies for prevention and health promotion among them. Secondly, the prevalence in this study was self-reported. Blood glucose, blood cholesterol level, and blood pressure were not measured. However, self-reported diabetes, hypertension, and hypercholesterolemia are common in epidemiological surveys, as subjective methods are costly and not economically feasible. Additionally, the accuracy of the self-reported data were highly correlated with physicians' records and were mentioned in many previous studies. Prevalence of self-reported diabetes, hypertension, and hypercholesterolemia among the elderly in Malaysia were high. Increase in the prevalence of NCDs might further increase demand for healthcare, especially in the area with high proportion of older age group. These findings are beneficial for the local healthcare system and essential for designing effective public health program and intervention to promote awareness and consideration to the heterogeneity within the older population and recognize the different needs of older adults. These are the reference for this study. And thank you. You can contact me and reach me at this number or this email. Thank you.